Hey guys, happy Saturday. Let's get right into this Q&A because you all asked some really good questions this week. Dr. Berg, please do a video on festoons. So, festoons, otherwise known as malar mounds, are due to a loss of midface volume. Festoons and under-eye bags are both common, but they are distinct under-eye conditions. Under-eye bags are caused by fat prolapse resulting from orbital bone resorption, weakening of the orbital ligaments, and the repositioning and shrinkage of fatty compartments around the eye. So, the content of an under-eye bag is fat, whereas the content of a malar mound, aka a festoon, is an accumulation of edema fluid, along with a little bit of muscle tissue and lax skin. Neither condition is going to be corrected by any kind of topical product, so stop looking for eye creams that are going to address that. There is also really no at-home device that is going to fix them either. Addressing these requires oculoplastic surgery. In the case of an eye bag, it involves the repositioning of that fatty tissue. In the case of a malar mound or festoon, it likewise requires tightening up, pulling up, and removing that loose excess skin and swelling. If you are unsure whether you have a festoon or an under-eye bag, one of the easiest ways to tell is to look up. An under-eye bag will become a lot less obvious, whereas a malar mound or festoon, they are the same thing, will not change with the position of your eye. Also, eye bags are fat, so they are a lot firmer and kind of rubbery when you touch them, whereas a malar mound or festoon is soft and squishy. A festoon will also be worsened by situations where you have fluid retention, like after a night of eating a really high-salt meal, drinking excessive alcohol, or if you have seasonal allergies, retaining fluid for whatever reason makes malar mounds more obvious, while under-eye bags due to fat prolapse may appear slightly more obvious with fluid retention. They themselves are not fluid in nature, but rather fat prolapse. Next, tips for dealing with allodynia. Allodynia is a term for pain that is elicited by things that are not commonly painful, like the lightest touch, a feather on your skin, or your hair brushing up against your face. These are not typically painful stimuli, but people with allodynia have abnormal pain sensations, so a lot of things feel painful that otherwise should not. Common underlying issues associated with allodynia are chronic neurological problems like fibromyalgia and migraine syndromes, as well as autoimmune inflammatory syndromes like multiple sclerosis or complex regional pain syndrome. It is not uncommon to develop allodynia with certain underlying nutritional deficiencies, namely certain B vitamin deficiencies, and of course in patients who have neuropathies. Interestingly, we are seeing a rise. It is not super common, but it is a rarely reported newly described side effect of GLP-1 medications like Ozempic and Wegovy, where people develop abnormal pain sensations, including allodynia. In those cases, the allodynia either resolves with discontinuation of the medication or a reduction in the dose. As far as how to deal with it, over-the-counter topical pain relievers that contain lidocaine, like lidocaine patches, can help. If your allodynia is not necessarily of a burning nature, topical capsaicin creams can really help because they elicit a burning sensation that leaves the nerves stunned and quiets them down for a while. That is really helpful not only for pain, but also for itch, as pain and itch have a lot of overlap. Topical menthol can also be helpful, and to a certain extent, pramoxine, although it is pretty mild. You want to make sure you are taking measures to protect your skin from unnecessary friction and trauma. I suggest sticking to loose-fitting, lightweight fabrics. Bamboo, for example, is really nice and smooth on the skin, as is cotton. There is also physical therapy that centers around desensitization, basically training your brain to process stimuli differently. And certain cognitive behavioral therapy approaches can likewise help reduce overall pain. Any kind of emotional stress you are going through is actually going to worsen this. That is commonly the case. So those techniques can also be helpful for managing emotional triggers. As far as medications go, there are gabapentin and pregabalin, which kind of calm the nerves. There is also a variety of antidepressant medications that can secondarily work to calm the nerves, like amitriptyline as well as duloxetine. These medications do come with side effects and may not be the best choice in older adults, but they can be very helpful in some cases depending on the extent of what you are dealing with. So it really is a comprehensive pain management approach, but it is something that dermatologists see a fair amount. A lot of times patients see that they are being prescribed an antidepressant or told to go to therapy, and they wonder if the doctor thinks it is all in their head. Pain is technically all in everyone's head because our brain processes pain. Any kind of emotional distress you are going through significantly heightens pain sensations and the firing of those nerves, making pain a lot more stubborn to treat. It is not that you are making it up or dreaming it up, but your brain is actively engaged in the pain. So, therapies that involve retraining the brain cognitively can certainly help. To clarify this, if you have ever known anyone who has lost a limb, an amputee can actually develop excruciating pain where their prior limb used to be. There is nothing there, but they feel agony and extreme pain. If you do imaging, those pain centers are actively firing. So it is real pain, even though there is nothing there that is technically painful. There is not even a limb there, but the brain perceives a threat. Pain is basically a way to protect us from perceived threats, but it does not always get executed rationally. Next question. What do you think of Cetaphil's new glycolic acid? Topical glycolic acid shows some promising preclinical research in cells in a dish and small animal models as an antioxidant and anti-inflammatory. However, true clinical trials in actual human volunteers are few and far between, so it is hard to say just how helpful it is. If you take a look at this particular product, which I have never used before, it also contains the workhorse of the skincare industry, niacinamide. That is a topical B vitamin with many well-established benefits as a cosmetic ingredient. It is anti-inflammatory, it is an antioxidant, it can help with skin glycation, it is anti-redness, it is very helpful for hyperpigmentation, and it can calm the skin. Many patients with acne find it beneficial in their routine as well. So I suspect that for people using this and appreciating benefits in overall complexion, radiance, and evenness of skin tone, it would not surprise me if the niacinamide is doing all the heavy lifting. As you guys know, niacinamide is so widely used these days that it has lost some of its marketing appeal, so brands have to throw something else in there to make you think that it is the feature ingredient. A lot of times they will hype up vitamin C, but when you read the ingredient list, the vitamin C they are using is one of the derivative forms. The ingredient likely benefiting you the most, or at least the one with the most data behind it, is not the vitamin C derivative because it is ascorbic acid that shows promise when formulated correctly, but rather the niacinamide. Now, this product also has epigallocatechin galate, a green tea polyphenol that shows promise for reducing sun damage in the skin and acts as an antioxidant. So those two things together are really exciting. Overall, this product looks interesting. It has hyaluronic acid, which helps with water content in the skin, plumping the skin surface, improving barrier integrity, smoothing the skin, and cutting down on dryness. It would not surprise me in the least if this is very good, pleasant to use, and fragrance-free. Cetaphil does a good job with their products, but I wouldn't hang my hat on the glycolic acid. In this necessarily transforming things for you above and beyond what you might already be getting from a niacinamide serum or another antioxidant serum. I have not tried it though. Can topical steroids be applied before or after hydroquinone, lactic acid, or adapalene? I have no irritation after applying these in various combinations, but I'm wondering whether any of them cancel out the other. You can apply the topical steroid either before or after the others. It is not clear that doing so limits the penetration of the others. They are frequently combined, specifically the combination of a topical retinoid, hydroquinone, and a steroid is a typical combination for hyperpigmentation, and they work together quite nicely to very robustly fade hyperpigmentation. The classic formulation is known as Kligman's formula, subsequently marketed as Triluma, but there are a lot of ways to DIY it by layering the three creams together. The question is, do you get the same extent of results, the same robustness, and the same rapidity of onset if you use three separate creams layered on top of one another, as opposed to the triple combination cream? That is not clear. I will say that sometimes compounded creams do perform better than using each of the ingredients layered in separate creams. That is just an anecdotal observation with a lot of things we compound in dermatology. or have the compounding pharmacist compound for us for treating conditions like atopic dermatitis. But all that to say, no, they do not cancel each other out. Now, you do want to be very careful. I don't know what topical steroids you are using, and they are not all created equal. Some are very potent and should never really be used on the face, and all of them can lead to side effects if used inappropriately. So it is always a good idea to make sure you are doing this under your doctor's supervision and that you know what you are treating. A lot of times, people will treat something with a topical steroid that really should not be treated with one, and it makes it worse and much more stubborn, like with rosacea or a fungal infection. So as long as this is something you are doing along with your doctor, they do not cancel each other out at all. In fact, they are commonly used together. Years ago, I had laser hair removal on my entire scalp and face. I am a male. Going through the process, they told me that the hair around the mouth, the mustache, and goatee is a lot more resistant to permanent hair removal and can often come back. This advice was accurate. While greatly reduced, the hair around my mouth keeps coming back. Will electrolysis permanently remove the hair around my mouth? Additionally, some of the hairs have gone white, which I was also told the laser could not handle. Will electrolysis also permanently remove white hairs? Electrolysis can offer true permanent hair removal, in contrast to laser hair removal, which offers permanent hair reduction, where you often need maintenance treatments later on for ongoing regrowth. Once electrolysis has zapped the hair, it destroys the cells that make the hair. Once that happens, it essentially causes a tiny scar, its own little follicle-specific scarring, alopecia, and the hair is gone and will not come back. So that is great. The problem with electrolysis is that it is very laborious and tedious. You need to go to a practitioner who is truly skilled in the procedure. There are very skilled people who do this, but it can be very laborious, and you often need multiple visits to treat more than one hair. But once the hair is zapped and done well, that is it. Electrolysis can be a bit more painful, but it offers true reduction. In contrast, laser hair removal ideally targets pigment in the hair. It is really good for dark hair on light skin. That is the best case scenario, because there is nothing in the skin tone to distract the laser. So it is quite literally laser focused on the pigment in that hair and zaps it. But if you have light-colored hair, white hair, or a deeper skin tone, it may not work. With a deeper skin tone, laser hair removal can also cause post-inflammatory hyperpigmentation. Electrolysis, on the other hand, will not discriminate based on the color of the hair or the background skin. You can still get post-inflammatory hyperpigmentation with electrolysis, but it can treat those lighter hairs just fine. It is just a lot more laborious. So all that to say, yeah, if you have a couple of stubborn, regrowing, light-colored hairs that did not respond to laser hair removal, I think electrolysis could be a great option. Electrolysis is really good for a couple of rogue chin hairs or unruly brows, but if you have an entire back, leg, arm, or bikini area, you are not going to do electrolysis for that. You would be in there all the time, it would get very cost prohibitive, and it would be a test of endurance. And as far as deeper skin tones go, we have newer lasers that are a lot safer for hair removal on deeper skin tones. However, you need to go to a dermatologist with expertise and experience, because a lot of people are performing hair removal using IPL, which is not technically a laser, and ending up burning patients with deeper skin tones. It happens a lot, and is a common complication that dermatologists see. People who went to a med spa, had hair removal with IPL, have a deeper skin tone, and ended up with horrific, disfiguring burns. Then those patients end up in our office to correct it. I use tretinoin 0.025% in a microsphere formulation at night, which I tolerate extremely well. However, the Eucerin dual serum with thiamidol makes my face burn in some places. I don't want to give it up since it's a great product for dark spots. I even tried applying the serum only in the morning and tretinoin at night. How do I use it so it doesn't burn my skin? Can I apply moisturizer first and then apply the Eucerin thiamidol? One way to reduce burning, stinging, and irritation from a topical product is to wait at least 20 minutes, or ideally up to an hour, after washing your face and doing your skincare routine. At that point, the hydration of the skin is not as plumped up, so products tend to be a lot less irritating. That is a common strategy for reducing burning and stinging with topical retinoids, but it can work with any topical product. You certainly can apply a moisturizer as part of that skincare routine prior to the Eucerin product. That can definitely help cut down on irritation as well, so that by the time you apply the Eucerin product, your skin is not dehydrated, but it lacks the water-swollen aspect of a freshly washed face. That would be one approach. I also suggest trying the eye cream from the Eucerin line, at least if you are purchasing in the US market. The eye cream is the only product in the US line that is fragrance-free, making it a lot gentler. I don't believe the percentage strength of the thiamidol is disclosed, but I personally did not care for the strong fragrance in the facial care products and could not use them long-term for that reason. Fragrance can commonly trigger stinging and burning, so switching to the eye cream version might be a gentler option for you. I never wear a bra. Is that a problem? This question came following last weekend's Q&A where somebody asked, I wear a bra around the clock. Is that a problem? Now this person wants to know if never wearing a bra is a problem. No, that is not bad for your health per se, but there are certain situations where it is probably not ideal. If you have larger breasts, you may find that you need to wear a bra for support to avoid upper back and neck pain, as well as shoulder discomfort, which is not uncommon. Some women, even while wearing bras, require a breast reduction procedure because of how much discomfort it causes. I always suggest wearing a bra if you are doing any kind of sport, running or jumping, because workouts can cause repetitive strain on Cooper's ligaments. That can result in the surrounding muscles tightening, leading to neck and shoulder pain, so you always want to wear a supportive sports bra for working out. The other situation where it might be best to wear a bra is if friction from clothing aggravates or triggers nipple eczema. In that case, you may find that you need at least an undershirt. If the elastic or band of a bra is what bothers you, you could wear a smooth fabric camisole instead. All right, guys, that about wraps up this Q&A. Hopefully, I was in focus the entire time, because a few weeks ago I filmed one of these, put the footage on the computer, and realized I was only in focus for the first question. I had filmed for an hour and 20 minutes, and I was nothing but a blur. I had to refilm the whole thing in a hurry to get it uploaded on time. It was a disaster. So I really hope I'm not blurry today, and I hope you enjoyed the video. Thank you so much for all of your excellent questions. If you have any questions you want me to address in future Q&As, just drop them in the comments of this video. Make sure to come back tomorrow for part 2 on Sunday, as I have a lot more questions to answer for you guys. If you enjoyed today's video, please give it a thumbs up, share it with your friends, and as always, don't forget your sunscreen and remember to subscribe. I'll talk to you guys tomorrow. Bye.